Welcome back to another episode of One Clear Vision, Advanced Eye Care with Dr. Sophia Capo of ABC Optometry and Vision Therapy. Welcome back.
Thank you so much. Happy to be here again and excited to talk about some new things today.
So we are going to discuss some of the clarity challenges for children, and let's open with myopia.
Yeah, so I wanted to talk about clarity challenges specifically because in adults, clarity is a lot simpler. So in adults, if you have a clarity problem, you get a pair of glasses. It's pretty strict, easy. They can fix it with glasses. In kids, it's a lot more complicated. So specifically myopia. Myopia is nearsightedness. Okay. Now what nearsightedness means is that you see near and it's more difficult to see things far away. So the reason why this happens is because the eye is either misshaped or there's an issue with the power of the eye. So think about it as myopia, you need a minus prescription. So someone who has a minus prescription. Now, if you need a minus prescription, that means your eye is either too powerful and we need to take some prescription away naturally, or your eye is too long. So in children who have myopic prescriptions, who need negative prescriptions, usually it's because the eye is growing too long. Now, we know, and all the new data that's coming out is telling us that when the eye gets too long, it actually increases our risk of certain health problems, such as glaucoma, which is damage to the optic nerve, or retinal detachments, which is when the back part of your eye rips or tears. So in children, if we start seeing a nearsighted prescription early on, again, remember, the earlier we catch things, the better it is. If we start seeing that their prescription is getting higher and higher each visit they come and see us, we actually have intervention now that can help us slow down the elongation of their eye and decrease the risk of getting glaucoma and retinal detachments and other maculopathies, so problems with our center vision. In adults, because they're already full grown, this doesn't usually happen. So kids, it's even more important to get into the optometrist early and to be monitoring this frequently. Sometimes I see kids every 6 months or earlier if their prescriptions are changing so much. And the technology and what we know in terms of our interventions are growing every single day. So we have things like eye drops that you put in your eyes every single day before bed that can help slow down the progression of nearsightedness. We have special contact lenses that we can put in our eyes that slow down the progression. We even have glasses that have special lenses, and those lenses have also been shown to slow down this progression. So it's not as simple as, oh, you have a small prescription, let's just throw you in a pair of glasses and we'll see you in a year or a year or two. There's more that we can do, and we should be doing, it's standard of care now to be doing these things even earlier.
So Dr. Capo, this is absolutely fascinating. I mentioned it before, I have 3 children, and the things I wish I knew then.
Yeah.
So early detection, coming in to see you. You're the only specialized trained pediatrician and vision rehabilitation specialist in the Okanagan.
Pediatric optometry is not pediatrician. Pediatricians are medical doctors. I want to clarify that.
You can check me all the time. I'll get it wrong. But this is huge. So definitely. Having you in the community, huge. Having you sharing this education, huge. I never knew negative and plus on a prescription. I had no idea. You make it so simple to understand.
Thank you.
So we have the opportunity to try and help our littles.
Definitely.
Early.
And it's even more important if the parents have nearsightedness. If the parents are myopic, then it's more likely genetically that children are myopic. So if you're nearsighted and you're a parent, bring your children in even earlier, because back then, like you're saying, when you were having kids, maybe we didn't have this technology and we didn't know that we were able to do these things. But now we have all this new information. And so it's our responsibility to make sure that we're targeting these kids at an earlier age. Another really funny thing that we know now is that the progression of nearsightedness, so genetics plays a role. So if you're nearsighted, then obviously your kids have a higher chance of being nearsighted. But also the amount of time we spend inside versus outside affects this. So we know from the research that children who spend more time outside are more likely to have lower prescriptions. So they don't progress as fast as the kids who spend more time inside or perhaps more time on screens.
Oh.
So the big message in myopia, especially if parents have nearsightedness, are get your kids outside, get your kids away from near things, and look at the beautiful weather that we have in It's easy. It should be easy here in the Okanagan to spend more time outside, especially now that the weather's great.
So that's nearsightedness. And you gave us so many options for helping
slow down the elongation of the eye that can cause those health risks.
So what about farsightedness or hyperopia?
Hyperopia, yeah, you got it. So farsightedness is, again, different in kids than it is in adults.
Fascinating.
So when someone is farsighted, it means that they see better far away.
Okay.
And then for kids, it just means that you have to work harder up close. Doesn't necessarily mean that you can't see up close. It just means that you have to work harder in order to see up close. So, for example, you know how when, like I'm sure everyone out there knows an adult who's over 40, and then your focusing system starts to slow down. So you start needing something called a progressive lens to compensate for that reduced focusing. So there we go. With kids, their focusing systems are super strong. So they have these crazy focusing systems that can actually cover up prescriptions that might be hidden, or, make up for a prescription. Even though they have it, they can kind of just accommodate for it. And so it's funny because farsightedness in children, again, means you see better far, but the system works harder to see up close. So it's not necessarily that you can't see, it just means that you're working harder to see. So the analogy that I like to use in these cases are sometimes, you're running a race. Two kids are running a race. One kid has more farsightedness than the other. So what that is kind of like that kid who has more farsightedness is wearing a backpack, and that backpack is filled with rocks. That kid can still run the race. They can still finish the race. They're still going to get to the end of the end and cross the finish line. But it's going to be a whole lot harder for that kid to run than it would be for someone who doesn't have that much of a prescription. And running in this case, what I mean by that is actually reading. So something that we're doing up close for long periods of time is reading. And so those kids who are farsighted, who see better far, but who have to work hard to see up close, tend to be slower readers. They tend to have worse vocabulary. They tend to have poorer reading comprehension. And so finding them and putting them in a pair of glasses, sometimes we put kids in glasses strictly for reading. So it's like we have a little kid who's wearing reading glasses, which is not something you typically hear. But in my world, in the pediatric optometry world, it's really, really common. And sometimes it's necessary to get these kids up to reading level. And it's something that's missed. And it's missed because of something we talked about in our intro, and that's the dilated eye exam. So for adults, we put drops in your eye. You ever had drops in your eyes?
Oh, yeah. Oh, yeah.
So it's not the most fun thing because it makes you blurry. For kids, we actually use a different eye drop, and that eye drop is stronger. So that eye drop is actually meant not to dilate the eyes so that we can check the health. That's why we use it in adults. The kids drop that we use is actually meant to block the focusing system. So kids, because their focusing system is so strong and because it can be used to cover up prescriptions, we actually put this drop in their eye to relax their focusing system. When we relax their focusing system, we're able to take a true measurement without their focusing system accidentally covering stuff up. And so sometimes, without a dilated eye exam, it might look like a child has a very, very small farsighted prescription that, doesn't really need to be corrected. Because kids, if they have a little bit of a prescription, we say, you're fine. You can overcome it. You're not having any issues. But sometimes we put the drops in the kids' eyes, And we find, oh my goodness, your system was covering up a huge prescription. And you were working way harder up close than we realized. And what's funny is that it doesn't correlate at all with clarity. So those kids who are covering up really, really big prescriptions and who might be struggling to read or might be working extra hard to read, they come into our exams and they're seeing 20/20 with each eye. So without that extra piece, without putting in those drops, how would we know?
Yeah.
And we're going to talk about this in a different episode about ADHD and ADD and autism and those correlations with certain vision problems. But we know that if we're not looking for these things, a lot of the testing that is done to look for ADHD and ADD, other learning disabilities, is visual. And so if these children have issues, hidden issues that their systems might be covering up, and if we're not looking to find those issues using our gold standard dilated eye exams, then these kids are writing these tests and we don't know if maybe they're not able to do the testing because their visual system is fatiguing so much from looking up close.
I just think that is so amazing what you just unpacked. And again, I can't even imagine where it's connected to or correlated to. And I'm guessing, I don't know if there's behavioral focus, confidence.
Yeah.
I think it would be connected to so many things. So
Absolutely.
Again, message, early detection, get tested, come in.
And come in even if your child is not complaining about not being able to see. The amount of hidden prescriptions that I find and the impact that we see on school performance after correcting these children for prescriptions they didn't even know they had is unbelievable. But it takes time. So coming into an appointment, we have to budget about an hour of time for these kids to come in because the dilation drops take about 30 minutes to kick in. So the gold standard is to wait that 30 minutes of time. And so it's like, you're coming in, we're doing some testing first, we're putting the drops in, and then we're waiting, and then we're seeing you back. So it is more of an effort. It takes more time. It's more of a commitment for parents. It's a little uncomfortable for the kids, sure, but it's necessary. And it's a step that should not be skipped, like every single appointment. And for the routine kids who have nothing, like we do it and we don't really find anything wrong, it's once a year.
Okay.
It's not that bad.
But if we're finding something, we want frequency in testing.
For sure. If we find something, sometimes we'll do it more often. Or sometimes we'll use even an extra strong drop, depending on what we need to find.
So Dr. Capo, what is astigmatism?
Astigmatism is not quite nearsighted or farsighted, but it affects clarity at both far and close.
Oh, good. Double whammy.
So double whammy. So astigmatism is due to the shape and the curvature of your eye. So for example, a lot of the times you'll hear like, oh, my eye's football shaped rather than being soccer ball shaped. Yeah. I don't necessarily love that definition, but a lot of people resonate with that because what it means is that if you think of a football, it's not perfectly round. So it has one edge that's a little longer and then one edge that's a little rounder. And that's basically what your eye does when you have astigmatism. So instead of having a perfectly spherical round shaped eye, you have two different curvatures that both need different powers in order to see correctly. So what all that means is that, for example, if you had the letter T, this part of the T needs one prescription in order to see this part clearly. And this part of the T needs a different prescription in order to see that clearly. And so what we do is in your glasses or in your contact lenses, we just integrate two separate prescriptions and then you see everything perfectly clearly. And it's pretty simple. We can fix it easy. But it doesn't mean that you can't see clearly far and close. It just means that things are kind of distorted in one direction. It's more of a shape issue rather than than the eye too long or the eye too short. It's more of just a curvature of the eye is not perfectly round.
And this is a forever thing. You don't outgrow this.
Yep. It's usually a forever thing. It is genetic a little bit. So parents who have astigmatism or certain races that are more likely to have astigmatism, we do see it commonly in kids as well. Sometimes we don't correct it. Sometimes we say, there's a little bit, but we'll correct it, when you need to drive or when you need fine detail, like you're trying to see things far away. These are the people sometimes uncorrected astigmatism is when you're driving at night and you'll see streaks through the lights. That kind of directional streak means the shape of your eye can be a little bit off. So that also is just another
but way again, we do not have 4-year-olds driving, so we're good.
Exactly. And we don't have 4-year-olds doing fine detail work, right? So a lot of the times, even when I see very small prescriptions of nearsightedness, a kid's world nowadays is very short, especially when they're really young. So this is why monitoring is important, and we'll make the decision. We discuss with the family, with the parents, and say, okay, what kind of activities are they doing? What do they need their vision for? Like, I have a 4-year-old at my clinic who does motocross and who has a really big prescription and who needs it because he needs to be able to see far away. Exactly. Yeah. But we also have, 4-year-olds who don't have those same demands. And so we work with them as long as there's not a developmental concern. And we'll talk about that in a different episode as well. But depending on how much farsightedness you have or how much nearsighted you have, that can actually affect how your brain connects with your eyes. And so sometimes we need to correct those things, not because the child can't see, but because there's a risk of changing the way your eyes are developing.
So again, detect, get the children in to see you, get the exams, and then we move into the glasses and contact lenses that will help adjust whatever's identified.
Yeah.
And allow them to do swimming and motocross and reading. And
definitely. Yeah. And we have so many active kids. We have like inserts that go inside ski goggles, for example, prescription swim goggles for the kids who have high prescriptions, but who need to be in the pool or in the summer on a boat. We have children who wear contact lenses successfully. I think the youngest that I've ever taught to put in contact lenses is 6 years old. Shout out, because she's awesome. In order for like our policy, in order to dispense contact lenses, is that the child needs to be able to put in and take the lenses out 3 times on their own with me watching. And so I had a 6-year-old who was very mature, and she had a really high prescription. And so she was very motivated, but she got them in. And so if you're able to do it and you're motivated and you're a clean kid, when there's support from the parents, like there are options out there for our littles for sure.
Amazing. Anything else you want to share with us today? Or I mean, you've shared so much, and I think education is key. So I think this is really important. As anyone watching this video, pass this on to anyone that you know has children, young or older.
Definitely. And I think, again, if your child, has been going for care and they haven't had a dilated eye exam, that's okay. That's absolutely okay. There's always time to go and get the gold standard test and to make sure that there's nothing wrong. There's never a wrong time or a delayed time. Again, we see children starting at 6 months old for their first exam and then usually annually thereafter. But if you're 5 years, if you have a kid who's 5 years old who hasn't come in yet, that's okay. Bring them in. And if there's an issue or if there's not an issue, we will have a discussion about it.
Dr. Capo, can I go off script for a second? Can you explain to me, you keep saying gold standard. Can you discuss, is that a brand name? Is it right?
So what I mean by gold standard is just the highest level eye exam that we can give to a child.
Okay.
So the highest level, what I would consider like a gold standard testing, like my future potential children, what they're going to get every single year. It's also what the medical doctors, the ophthalmologist, the eye surgeon will make sure that every single kid has at every appointment.
Okay.
And so I just call it that's the gold standard. That's how it should be. We shouldn't veer away from the gold standard, even though it might be, a little bit nervous to have the kids have these eye drops in their eye. It might take a little bit more time. It's worth it. It's worth it because we see every single day children who benefit from it, and who haven't had it in the past, but who maybe really needed it earlier the better.
Dr. Capo, thank you so much for coming in and sharing with us. Extremely informative, and get in and get checked.
Yeah, thank you so much. I'm excited next week to talk about not necessarily the clarity challenges, but some other visual coordination challenges. So I'm looking forward to discussing that too.
Love it. Thank you.